What do we do? Well, to manage withdrawing benzodiazepines, we've got to do a progressive reduction using a long-acting benzodiazepine. For those people with normal liver function, we typically use diazepam, and it's probably the gold standard. If we do an abrupt reduction, the patient tends to get rebound anxiety and insomnia. In actual fact, I've written that in the slide there, but I've used the wrong term. I should have written an abrupt withdrawal gives the patient withdrawal anxiety and insomnia, and that's my mistake. Rebound anxiety is where the underlying condition has been sufficiently medicated and returns on cessation of the drug. Withdrawal anxiety is where the actual absence of the drug itself causes the anxiety. So an example would be if somebody was on paroxetine and paroxetine was discontinued and then the anxiety returned. That would be rebound anxiety, provided the paroxetine had been discontinued over a sufficient period of time. We tend to find in placebo-controlled studies that when we withdraw benzodiazepines, we do not get a rebound anxiety. In actual fact, we get a withdrawal anxiety. And that's because we know that unlike the SSRIs, benzodiazepines, after a month of use, are doing nothing to treat the underlying anxiety. And one of the two reasons we want to discontinue benzodiazepine maintenance is we know that the benzodiazepines themselves are very efficacious for 2 to 3 weeks. After a month, they stop working. We do not want that abrupt discontinuation because it only reinforces in the patient's own mind their need for this substance. We want a single prescriber, just as we have for S8s. The gold standard is to have a single prescriber for every hypnotic, every benzodiazepine. And that single prescriber should be in liaison with a specialist if the patient is a polydrug patient. That doesn't mean that the general practitioner can't prescribe for that patient, but that should be in a shared care arrangement under the guidance of an addiction specialist if the patient is a polydrug user. And we all have to check with the prescription shopping service, info service, whenever we're prescribing benzodiazepines, not only to a new patient, but to any patient we've been in contact even with the time, because patients on benzodiazepines for long enough can start to destabilise and become benzodiazepine dependent. How do you manage withdrawal management? Well, the first thing is you've got to have a good therapeutic relationship with the patient. The old joke about how many addiction specialists does it take to change the light bulb? The answer, of course, is one, but the light bulb has to want to change. So we can only help the patient if the patient is agreeable. We can't force people to go through a withdrawal regimen, but we're on the patient's side. So we're about empowering them so that they're in control and the substance is no longer in control. We initially have to stabilise the dose, preferably with a long-acting benzodiazepine. And Professor Heather Ashton, who you saw earlier, came up with the manual, the Ashton manual, about how to do that, to sort from one benzodiazepine to another to stabilise. And once we are on a long-acting benzodiazepine of equivalent dose, begin a gradual dose reduction. Flexibility is essential, and I sometimes think it's a little bit like fishing. We've got to move with the patient, and they might be going through periods of difficulty in doing their reductions, and give them a little bit of leeway. The risks associated with trying flexible approaches are much lower than the patient, the risk of the patient discontinuing therapy. And we always try to develop an individualised treatment regimen. And the best way to reduce symptoms is by careful, flexible, tapered withdrawal of the drug. There's a trade-off between rapid withdrawal with intense, relatively short duration symptoms and slow withdrawal with protracted, less intense symptoms. If the withdrawal is done over 6 months, the actual withdrawal symptoms would be slight. This is the master herself, Professor Ashton, about 25 years ago, describing how to do it.
The size of each dose reduction depends on the starting dose. Patients on high doses can usually tolerate a larger dose decrement than those on lower doses. For example, patients on the equivalent of 40 milligrams diazepam can usually tolerate, say, 2, sometimes even 4 milligram reductions every couple of weeks. When they get down to less than 20, reductions of 1 to 2 milligrams every week or two is usually preferred, and maybe even half milligram reductions when they get down to 5 milligrams. Stopping the last few milligrams is often seen by patients as particularly difficult because of fears of how they'll cope without any drug at all. However, the final parting is often surprisingly easy as confidence increases and patients are encouraged by their newfound drug-free freedom. And the general aim of the dosage tapering strategy is to achieve a slow, steady, smooth fall in concentration, blood concentration of the benzodiazepine, allowing time for the necessary pharmacological and psychological adjustments that I've mentioned. And this may include actual resynthesis of GABA benzodiazepine receptors, which have downregulated during chronic use, as I explained earlier.
We've got to provide clear information that the aim of treatment is to produce safe stabilisation and progressive dose reduction, but we're not promising the patient they'll be entirely asymptomatic. We're looking for safety rather than symptoms. We always try to have the patient on only one benzodiazepine, and if they do not have liver failure, that's usually diazepam. If they have significant liver failure, it's often oxazepam. Now, patients may often say that shorter-acting preparations are the only ones that work for them, but we can't support the use of short-acting benzodiazepines. They make the withdrawal more severe and they're more likely to be misused and diverted. If the patient stabilises on a dose of 40 to 80 milligram of diazepam daily, withdrawal should be at the rate of 5 milligram per week until the dose reaches 40 milligrams, then 2.5 milligrams a week. And to go down from 80 milligrams of diazepam equivalent will take nearly 6 months. And that's a steady reduction regimen which is appropriate. A maximum rate of withdrawal, which I would usually avoid, it would be to reduce the dose by 10 milligram weekly until 40 milligram, then 5 milligram at weekly intervals. This will take 12 weeks. In my experience, someone reduced from 80 milligrams does better with a longer period of time. And during withdrawal, patients should be monitored with clinical reviews and by checking the prescription shopping service, because quite often patients will be doing a withdrawal and topping it up with other prescribers.